السلام عليكم طلاب. بالنسبة لمحاضرتنا اليوم احنا بلشنا بالdiseases of the pulp because this course is endodontic, which means that I will deal with the disease pulp. We started with the disease of the pulp and how it will be progressed to the periodontal ligament, and now we will see if there is any periapical lesion which is not from an endodontic origin. It is not from the pulp. But before beginning, yes, I need the arrow to show you. So here, when I am here, I can say I can remove the pathology and everything will be fine. But once the inflammation reaches this side, it will be infection then, so I have to remove the pulp. Otherwise, I will have another problem. And again, as I told you, that having an abscess, a pulp abscess, is rare because of the limited cavity of the pulp. Okay, mostly such an abscess will be directed to a spread of infection through the apical foramen, but sometimes it is there. So how you can diagnose it? The diagnosis for you should be histopathologically. Just check that there is no odontoblast process here. While there is there's vasodilatation and there is inflammatory cells. So a rise in the pulp pressure within an inflammatory exudate, and there will be local collapse of the veins. Okay, so there will be impairment in the blood circulation, a local hypoxia and anoxia. Then we will end up to abscess. Also, as I remember, I told you that I cannot differentiate, and I said when there is adaptation of the human body to the toxins that comes out from the pulp toward the periapical area, we will have something we call it granuloma. Either a granuloma will be there or there will be a periapical abscess. It depends. And always remember about the balance between the toxin and the defense mechanism I talked about in the previous lecture. So the etiology of this, from an infected tooth, an infected pulp end up to a necrosis, and there will be some toxins coming out with such a low-grade infection and defense mechanism getting adapted to these toxins. We might have granuloma, and that, as I told you, you cannot differentiate it by X-ray. Once you extract the tooth, you can see the granuloma, and that granuloma, if stays, it's granulation tissue. For just to remind you, what is it? It is surrounded by some epithelial. It is all epithelial cell, and that epithelial cell undergoes necrosis, and due to the lack of the blood supply, it will turn to be a cyst. A cyst means liquefaction in the center. Progression, and this is again a repeat for the pulpitis, that it could be acute or chronic, symptomatic or asymptomatic. If it is neglected, it will end up to apical periodontitis, which again could be acute or chronic. So either it will form a granuloma that will, if it stays, it will be a periodontal cyst, or it will form an abscess, either acute or chronic. And this is, once I told you, there will be a sinus sometime that releases the pus through. If there is none, I should expect osteomyelitis. as a progression, and that means that the infection is there in the bone, could be focal, could be diffused. Periosteitis could be with abscess, and maybe it will end up to cellulitis. Cellulitis means, you know what is cellulitis? It's an infection. So again, if we come to the osteomyelitis, it is just acute inflammation of the marrow tissue. It will spread exudate through the marrow spaces. Again, thrombosis of the vessel due to the compression. Because of the exudate, it compresses the blood vessels and reduces the blood supply. We will end up to necrosis of the bone, and there will be a lot of dying cells, and pus from the bacteria fill all the marrow spaces, and that involves the cortical plate and lifting the periosteum, causing further necrosis. And that is what then this will stimulate the action of osteoclast, and we will end the regeneration with transformation, which is the osteomyelitis. I am just trying to refresh your information, because all what was there, we were talking about infection in the periapical region in the bone, coming from an infection from the pulp, which is also coming from a neglected carious lesion. But can a periapical lesion comes from a non-odontogenic origin? Yes, it can. A trauma can do. Foreign bodies, fibro-osseous lesion, benign or any malignant tumors. But what is cellulitis really? It's a spread of infection through the cells of the face. Okay? It's a symptomatic odontoedematous inflammation associated with diffuse spread of invasive microorganisms through connective tissue and facial plants. So, clinical feature, you can see a diffuse swelling on the face and the cervical area, and mostly cellulitis, it's again from a neglected infection in the apex, from an apical abscess, okay, that penetrates the bone. Sometimes there is a penetration through the bone causing a fistula, we call it, or a sinus. If it is in the same cavity, we call it a sinus. If it is connecting between two different cavities, so it will be a fistula. So if the pus was spreading through these, I don't expect cellulitis. But if it was surrounded by tissue, then there will be other ways. To the facial structure, the pus will be spreading. You see clear from the asymmetry between the two halves of the face. Okay, it will pass to the facial planes, between the muscles, okay, between the different fascia of the face and the neck. It may have some systematic symptoms or may not, like fever, malaise, okay, but it is a sequelae of uncontrolled apical abscess. So spreading an infection to the adjacent connective tissue may or may not add other complications, like life-threatening complication, because we have many spaces, as you remember, surrounding the mandible. We have the Ludwig angina, orbital cellulitis, and cavernous sinus thrombosis, and even death sometime from a brain abscess originating from spreading dental infection. What's the relation between the apical periodontitis and other systemic diseases? This line will be repeated again. I think it is at the last slide. People with compromised health, like diabetic patients, especially when it's uncontrolled, it's very difficult for a periodontitis, an apical periodontitis, to heal normally. There was always either failure in healing or a delay. So, how this healing can happen in the apical periodontitis? First, removal of the irritant. What's the irritant? It's a toxin from the bacteria that comes from where? That comes from the infection of the pulp, whether if it is chronic or subacute. So, we remove that pulp. We do either endodontic therapy or a surgical apicectomy. So then all the inflammatory mediators will be removed and the tissue will heal. So what do you have in the periapical region? We have tissue of the bone, we have tissue from the cementum, and we have the collagen fiber, which are the periodontal ligaments. And as you remember, when I mentioned the cementum, there was a reservoir of growth factors, many types of growth factors, cementoplasts and osteoblast on the bone side. So a non-surgical root canal treatment is intended to remove irritants and provide favorable microenvironment conducive to regeneration of periodontal tissue damage by apical periodontitis. So, which means that once I remove the irritant by a successful root canal treatment, then the healing will appear to be programmed events. So, extensive fibrosis do not occur often, and damage of the periapical tissue can be restored, mostly from the original structure, which means that the bone, the cement cells will work. So there are many viable periodontal ligament, even cells in the periodontal ligament, even from the adjacent root surface. So they will proliferate to cover the root surface of the damaged tooth. And all the damaged tissue due to the inflammation from the apical periodontitis will be removed by the macrophages. And as I told you, we call them scavengers. يعني in Arabic makanis. Okay, they will engulf all the damaged tissue. For them, these damaged tissues are formed by proteins from Hertwig's epithelial root shell, okay, are required for cementoplast differentiation. From where? From the ectomesenchymal stem cell and the dental follicle during tooth development. Remember these stem cells? The bell shape and so in the tooth. There is always a remnant of the herpes. The extracellular matrix, the growth factor of the cementums, if you remember, all of them were mentioned, the bone morphogenic factors, all these, okay, the sequestered cementum resorption in mature teeth, they are capable to be induced again. They will induce cementum by proliferation, migration, attachment, and differentiation of multipotent stem cell in the periodontal ligament into cementoplast-like cell. They will produce the cemento tissue, and to cover the denuded part of the periodontal ligament. Root resorption that involves cementum of both cementum and dentin can only be repaired by cementoid tissue. because the multipotent stem cells of the periodontal ligament are incapable to be differentiated to odontoblast. So, to produce dentine. So the result, if we have some external resorption, it will be repaired by cementum, not by dentine. Bone, everybody knows that the bone is remarkable in regeneration. After energy, a continuous remodeling is existing in the bone. So during the periapical healing, the osteoprogenitor cell or mesenchymal cell, with the presence of all the endosteum-stimulated factors and the growth factor, the cytokine released from the stromal cell, osteoblast present, platelets, bone matrix, all of them, they will go under proliferation, differentiation into osteoblast to produce bone matrix. Yes. Again, even if there is a sinus, even if part of the buccal or the lingual plate is destroyed, the osteoprogenitors can align the area, and there will be an inner layer of periosteum beneath the oral mucosa stimulated by these growth factors. Okay. Here again it's telling you that even if there is a buccal and lingual or palatal cortical bone plate destroyed by large apical periodontitis lesion, even that is kept healed. Everything, if the bone is healed and then the cementum is healed too, then the periodontal ligament, the mature periodontal ligament, the collagen fibers, Sharpie's fibers, again will be inserted, part of them in the cementum, and the other part is inserted in the alveolar bone, and everything can go back to functionally, physically, and so on. Can a radicular cyst or apical periodontitis lesion, if it was pocket or true cyst, is it possible to heal after an endodontic treatment, a non-surgical endodontic treatment? Yes. Till now, there is no study that tells you that there is no healing or there is a complete healing. But in pocket cyst, the apical periodontitis lesion might regress after root canal treatment. Mechanism of apoptosis, programmed cell death based on molecular cell biology, this all will be healed. In apical true cysts, because it is not related to the not connected to the pulp, like here, this one is the true one, there is no connection, they have less chance to be healed completely because they are sustained type. Biologically, it is unlikely that hyperplastic epithelial cell of inflammatory apical true cyst would suddenly transform into cells that behave like self-sustained neoplasm. Biologically, it is unlikely. So these are just studies. A radicular cyst, can it regenerate? Regression of radicular cyst and regeneration of bone after root canal treatment may occur. Okay, so during progression of radicular cyst, part of the cystic lining epithelium could disintegrate due to apoptosis of the local epithelial cell. and that can allow the fibrous connective tissue that will grow and take a place of the lumen into the lumen of the radicular cyst, and then the cystic lining of the epithelium. What are the factors that affect the healing or delay the healing of the periapical area after endodontic treatment? Definitely, infection will complicate and prevent wound healing. If I have my seal of the root canal is not successful, okay, foreign body can impair wound healing. Nutrition can affect healing because it affects immunity. Diabetic patient, as I said, it will reduce the likelihood of healing. Impaired immune response, patient with deficiency with immune response, also some disorder in the vascular system will impair the healing. Patients with undergo radiotherapy or taking bisphosphonates therapy mostly are the patients that having with the neoplastic problems. Patient with cancer under chemotherapy, they give them bisphosphonates, so they have the risk of osteonecrosis of the jawbone, so must be there. What are the causes of the persisting apical periodontitis? Maybe the intraradicular infection persisting in a complex apical root canal system that affects my root canal treatment. Extraradicular infection from the periapical actinomycosis, a type of bacteria is difficult to heal. Okay, extruded root canal filling and other oxygenous material that cause foreign body reaction. Okay, accumulation of endogenous cholesterol crystals. Also, they are irritant to the periapical tissue. These crystals are normally present when there is pus. True cystic lesion. When it is really a true cystic lesion, it is not progression of the pulp infection. They will be also persist. Scar tissue sometime after healing. Maybe it is again related to the balance between the immunity and also it affect my So what are the morphological changes of the apical root structure in apical periodontitis lesion? Either I will have a root resorption or I will have cementosis. So either I will have a removal of a cementum because of the presence of a multinucleated class cell as odontoclast, and that is a pathological root resorption, maybe caused by traumatic injury of the tooth or because of the neoplastic process in the jaw, dental treatment procedure, for example, orthodontic force, intentional replantation are most common. So this can cause such as root resorption in apical periodontitis. I mean the apical periodontitis mostly are caused by these causes, by trauma, by ortho problem treatment, okay? So depending on the amount of the calcified loss, a root resorption can be detected by periapical radiograph. So to decide, I need a periapical radiograph, okay? But again, to know why is that resorption? Is it due, which is not of odontogenic origin definitely. Mostly I need a histological section. Radiograph is not enough. It will just show me the resorption, but what is the cause? Now I need to make biopsy. osteoclast, osteoblast, all are similar enzymatic properties to resolve their target tissue in similar manner. The bony tissue leading to resorption. So normally osteoclasts they adhere to a non-mineralized layer of the pre-cementum covering the apical here, covering the apical root surface. Similarly, in the internal resorption, okay, where a breach of integrity of the predentine and odontoblast layer is necessary for resorption to occur. The pre-cementum and the cementoblast layer need to be lost in order to stimulate cementum resorption. The pre-cementum and the cementoblast should be lost to stimulate cementum resorption. Then the cementoblast will take place. They will adhere to that area exactly as the half-shoe-like uni, and due to their enzymes and due to their acid production, they will cause the resorption. The hypercementosis, so either I will have resorption or a hypercementosis. But hypercementosis is less likely to occur. So the deposition, pathological deposition of several layers of cementum around the apical can be observed sometime with some peri-radicular lesion. And thank you.